Florida. I went to Harvard undergrad, Cornell for medical school, and Duke for general surgery and plastic surgery. I've been in private practice in Fort Lauderdale for the past 12 years, and I've specialized in breast reconstruction for most of that time, as well as some cosmetic breast surgery. And my main interest in breast reconstruction came because my mom had breast cancer when she was 40. Unfortunately, she also had ovarian cancer last year when she was 67, and we found out that she was BRCA positive, and so am I. I had my first surgery 3 weeks ago, so it is a pleasure to be here to talk to you not only as a doctor and an expert in this field, but also as a patient. I'm happy to discuss my journey with everyone when time allows, but right now we're going to focus on breast reconstruction with tissue expanders. So let's talk about some of the facts. In 1998, a law was passed, the Women's Health and Cancer Rights Act, which mandates that insurance covers breast reconstruction for women who've had mastectomies. Still, in the early 2000s, only about half to a third of women who had mastectomies were getting reconstructions. So last year, another law was passed, the Breast Cancer Patient Education Act, which mandates that healthcare providers inform women who are getting mastectomies about reconstruction options. And this has helped in the number of reconstructions. The blue line at the top shows the number of reconstructions is going up over time, and the number of autologous reconstructions, which means using tissue from your own body, the dotted line in green has more or less stayed the same. But the number of reconstructions using implant techniques, the reddish line in dots, has gone up. So this is myself and my partner, Dr. Laura Sudarski, performing a breast reconstruction. And people like us perform about 100,000 breast reconstructions a year in the United States. So that's the first column. The second column in the second bar in the graph shows that 77,000, or over 3/4 of those reconstructions, are done with tissue expanders, which are then exchanged to implants. The smaller graphs show direct-to-implant, DIEP flaps, latissimus dorsi flaps, tram flaps, and other reconstructions. So for my next few minutes, I'm going to focus on what the majority of women are getting at this point in time, which are a 2-stage tissue expander to implant reconstruction. This can be done in an immediate fashion, which means exactly at the time of the mastectomy in a concurrent surgery, where an oncologic surgeon performs the mastectomy and a reconstructive surgeon performs the surgery in the same setting. The benefits of this is reduced surgeries for the patients, lowered costs, and the psychological advantage of waking up with a breast round. For women who have more advanced disease or who really need to get to chemotherapy or radiation much faster, there is always the option for delayed reconstruction, which means happening at a later point in time. Throughout, tissue reconstruction with a shaped device has a special valve that you can gently use to fill the expander to create a breast mound. And in this day and age, this can be performed either with saline or with air. A traditional saline expander is placed under the muscle and often with the use of an acellular dermal matrix at the time of mastectomy, or like I said before, if need be, in a delayed fashion. And the device is filled in the office weekly, at the plastic surgeon's office, either by the doctor or by a nurse in the office. This requires a needle. We have a magnet that helps you find a self-sealing port, or sometimes they have a remote port, and we use the needle to fill the expander. There's some discomfort and some risk of infection using this, and the process is slow. I generally put, not sure why it's flashing, I generally put 50 cc's in at a time when a patient is getting a saline expansion. So this process takes 3 or 4 months, sometimes even longer if the patient needs chemotherapy. And then once the tissue is adequately expanded and a breast shape is made, the expander is changed out to a permanent implant. I was fortunate enough to be one of 17 sites in the country to participate in an FDA clinical trial about an aeriform tissue expander. This is a device that fills with air that is a new development in tissue expansion, probably the most radical in the past 30 years, that offers women control, convenience, and comfort. This is a picture of the expander and of the remote control used to fill the expander, and this is my partner and I putting one in the OR and pairing the remote control to that expander. So with the aeriform system, this is a needle-free system. The device itself contains a canister of CO2. The patient controls when that CO2 is released to fill the expander by itself. The patient doses according to her own comfort level in the comfort of her own home, and this eliminates the need to go to the doctor's office for those weekly fills. Because the patient is in control, we have found that women expand much faster, on the order of weeks instead of months, using this device. So when she pushes the button, 10 cc's at a time is released from that little CO2 cartridge into the implant. That's a relatively small volume. Most people don't feel anything when that happens. There's a 3-hour lockout, so you can't dose again for the next 3 hours. And the maximum number of doses you can do in 24 hours is 3. So if you did that maximally, you would put 210 cc's in a week, as opposed to the 50 cc's a week that we put in with saline. And the control is limited. You can't pump it up as big as you want to be and overfill them. There's a stop end on it, although many people, mostly the husbands, have asked. But I hope I've explained to you a little bit about some advances in tissue expander reconstruction, because that is still what the majority of women in this country are getting for their breast reconstruction techniques. Thank you so much for your time.